Temporomandibular disorders, the anatomy and kinematics. The bones that make up the TMJ are the temporal bone and the mandible. The head of the condyle is the part of the mandible that articulates with the temporal bone. The temporal bone landmarks. The key temporal bone landmarks are the mandibular fossa, where the mandible sits. This articulates with the articular eminence and the crest of the fossa. Also, the external auditory meatus, which makes up the posterior wall of the TMJ. Here are the landmarks of the mandible. The key landmarks are the condyle, the neck, and the head. Also, the lateral pull on the outside of the head of the condyle, which can be palpated at rest and throughout the range of motion. Variation in the mandibular condyle. Variation in size and shape is normal. Shown above are 4 different types of condylar heads. The first is flat, second is convex, angular, and round. Bony asymmetries can affect mandibular dynamics, like the slope of the eminence, the angle of the long axis of the condyle, and the shape of the condyle as demonstrated previously. These asymmetries can cause deviation, which is an S-curve, deflection, a C-curve, or also midline straight opening. Variation is normal. Is it pain-free and is it functional for the patient? The functional anatomy of the TMJ. The TMJ is a synovial diarthroidal joint. The mandibular condyle lies within the temporal fossa. Some special features of the TMJ are that the TMJ and disc are covered with fibrocartilage. The disc will divide the joint into a superior and inferior compartment. Each TMJ on the right and left must work together. Dental occlusion or problems may affect the kinematics of the TMJ. The articulating surfaces of the TMJ are composed of fibrocartilage and not hyaline cartilage. Fibrocartilage is less susceptible to shear and load and has a greater capacity to repair and remodel, as the TMJ is a joint that you use 1,000 times a day. Features of the articular disc. The disc separates the TMJ into upper and lower compartments. The posterior and anterior aspects of the disc are innervated. The anterior disc is attached to the lateral pterygoid, as seen in the picture. The posterior disc is attached to retrodiscal tissues and superior and inferior lamina. The disc is the likely source of joint noises and pain. The TMJ is innervated by the trigeminal nerve. The 3 branches listed below are primarily responsible for sensation and motor to the muscles of mastication. The posterior and lateral aspects of the TMJ have the greatest density of nerve endings. These are both C and A delta fibers. C fibers relay nociception, temperature, and are not myelinated. A fibers transmit impulses related to muscle, tendon, and articular movement. The muscles involved in the movement of the TMJ are the medial and lateral pterygoid, the temporalis, the masseter, and the hyoid muscles. The masseter is the main muscle of mastication. A unilateral contraction, or a contraction of just one masseter muscle on the right or left, will cause lateral deviation to the same side. A bilateral contraction of the masseter muscles will cause elevation of the mandible. The masseter is also used to create further force when chewing and or grinding. The temporalis muscle. A unilateral contraction will cause lateral excursion to the same side. Bilateral contraction of the temporalis will cause elevation and retraction of the mandible. The medial pterygoid. Made up of deep and superficial heads, a unilateral contraction will cause contralateral deviation. Bilateral contraction will cause elevation and protrusion. The lateral pterygoid. consists of a superior and inferior head. Unilateral contraction will cause contralateral excursion. Bilateral contraction, with the superior and inferior together, cause protrusion. Inferior by itself helps the depression of the mandible with opening, and superior by itself may eccentrically contract to monitor disc protrusion to avoid displacement. There is very little research to show what the superior muscle head will do individually. The suprahyoid muscles are used while the mandible is fixed. They will cause depression and retrusion of the mandible during this position. Here is a chart of all the muscles in mastication. Looking at the function of the TMJ joint, whether that be elevation, depression, protrusion, retrusion, or lateral excursion deviation, listed next to it are all the muscles involved with those movements. As you can see, the masseter, as the main muscle of mastication, is used during numerous of these movements of the TMJ. Here is a video showing you the kinematics of the TMJ. The kinematics of opening. During the initiation of opening, posterior rotation of the condyle occurs. The condylar head is moving anteriorly, but the body of the mandible is moving posteriorly. Rotation will continue as translation occurs during the rest of the range of motion during opening. Anterior translation occurs of the condylar head and the disc as a unit. Initially, the disc will rotate posteriorly. This occurs to keep the non-innervative fibers on top of the condylar head as they translate anteriorly. Rotation still occurs as translation occurs throughout this full range of motion. Elevation, closing, will have posterior translation along with the disc, and the condylar head rotates anteriorly. Again, the non-innervated middle portion of the disc is maintained between the condylar head and the articular eminence. Protrusion and retrusion. During protrusion, the condylar head and mandible will translate anteriorly and inferiorly with the disc. During retrusion, the condylar head and the mandible translate posteriorly. Lateral deviation. The ipsilateral condyle will rotate, the contralateral condyle will translate.